A very good afternoon to all and wishing you all a very happy Dashera. On this auspicious occasion, the Ludhiana chapter of Society of Fetal Medicine, have brought this program under the guidance of Dr. Ashok Khurana. And without much further ado, I would request our president of the Ludhiana chapter of SFM, Dr. Deepak Bansal, to formally welcome the delegates. Over to Dr. Deepak, please.
So you're muted, sir. Yeah.
Deepak, you have to unmute yourself.
I'm sorry for this. Just forgot to unmute myself at the right time. So this is today. This is such an auspicious day. At the outset, I would wish everybody, every delegate, every faculty, and Dr. Liona Poon as well, a very happy Dashera and Vijay Dashmi. Today is Sunday, and on Sunday, the Society of Fetal Medicine is conducting its first regional session. And as you know that during the COVID days and the post-COVID days, this is probably, this is of course the first time that Society of Fetal Medicine took this initiative that we can conduct our meeting online. And for this, we are so thankful to Dr. Liona Poon to have agreed to join us. We could not have thought of such a situation where we have seen so much of academic work from Dr. Liona Poon, generally and especially in the field of pre-eclampsia. This has been such an inspiration for us, and I really, on behalf of Society of Fetal Medicine executive body and from all the delegates, I welcome Dr. Liona Poon here on this day. I also welcome Dr. Ashok Khurana, sir. He has been a leading light in the field of fetal medicine in India, and I always say this, that he has single-handedly led this movement of fetal medicine from the front. And that is why we have today whatever knowledge of fetal medicine spread horizontally amongst everybody, just not in this part of India, North India, in entire India. So I really welcome you all, Khurana sir. And on Sunday, we have already got more than 100 participants already joined in. I think approximately 150 have already joined in. And I think hundreds of participants will join. I welcome you all from the bottom of my heart. And this is such an important topic we are discussing today. And for the topic, I would leave everything for Dr. Liona Poon, and later for panel discussion for Dr. Ashok Khurana, sir. Over to Dr. Ashok Khurana to introduce Dr. Liona Poon for us. Khurana, sir, please.
Thank you. Thank you, Deepak, and thank you for always being there to lead such an important part of the country and make sure that the women do well and that every fetus gets an optimal outcome. It is indeed a pleasure to be here at this virtual meeting today. And it is also my pleasure to welcome Dr. Liona Poon. She, for us, represents not only her position at the Chinese University of Hong Kong, but her background and experience at the Fetal Medicine Foundation of the United Kingdom, which we all admire so much. For all of you who want to get inspired, I want you to know that when we got the results of the ASPRE trial, she was the mind behind taking all those blood pressures day in, day out, persistently, without thinking it is a low-down, mean job to do, thinking that this is what is going to save the lives of all those women who die because of preeclampsia, not to mention the number of premature deliveries that get done because of uncontrollable blood pressure. And I also want you to know what a wonderful friend she is of India. A few years ago in 2017, the Society of Fetal Medicine had the pleasure of hosting APC-MFM, which you know was a huge success. We had it here in Delhi, in Gurgaon. and we had her there. She conducted this excellent workshop and introduced us to the concept. We've felt that it hasn't grown ever since. We felt it should grow much more. And she was so kind to have agreed to do this program. And we use this then as a stepping stone to go to other regions and make sure that all those women who are not going to be alive or who are going to be damaged completely by the time they're through with pregnancy, that's not going to be happening to them. Do remember that at the end of this program, we would have had 41 women all over the planet dying of complications of preeclampsia. And the amount of morbidity that those babies are going to have is another story altogether. And so much of this is preventable, as we are going to learn. Thank you so much, Liona, for being with us this afternoon. I know it's later in the day in Hong Kong. And thank you also for promoting the cause of India at ISWAP. That has been always very kind of you. And now that you're on the board of trustees, we really know that you're going to push our cause there as well. Thanks ever so much. And now the floor is all yours to tell us about not only screening for preeclampsia in the various trimesters of pregnancy, but also how to use this information and do an appropriate surveillance so that we have the best outcomes. Thanks for being here, and the floor is now entirely yours.
Hello, India, and good day to all of you. Thank you for your kind invitation and your introduction. I mean, it meant a lot to me. So today you have to listen to me for about 50 minutes on the topic of prediction and prevention of preeclampsia. So I do hope you won't get bored, and but I will try my best to keep it as lively as possible. First of all, here are my disclosures. So as I already mentioned, my talk will cover two parts. One on prediction, and second, prevention of preeclampsia. So let me just start on prediction of preeclampsia. There are two professional recommendations that we often make reference to. The first is the NICE guidelines from the United Kingdom, and the second is the ACOG guidelines from the United States. They are rather similar, as you can see in this slide. If a woman has one high risk factor or two or more moderate risk factors, then she is considered to be high risk, and she is advised to take 75 milligrams or 81 milligrams of aspirin from 12 weeks till the birth of the baby. The approach is simple, but its predictive value is limited, achieving only 39% detection rate for preterm preeclampsia at a screen pass rate of 10%. It was clear that we needed to improve the method of screening for preeclampsia. When I was firstly involved in this work, we used logistic regression to combine a series of maternal factors with the measurements of biomarkers to calculate the risk for early, preterm, and late preeclampsia. This approach does give personalized risk, but we have to fix gestational age at delivery cutoff for preeclampsia to define the severity of the condition, such as less than 34 weeks, less than 37 weeks. A limitation relates to the fact that the algorithms cannot be easily expanded to include additional biomarkers. So every time, one must run a new regression analysis to test if a potential marker is predictive of preeclampsia. Also, the algorithms do not take into account the increasing effect of biomarkers with severity of preeclampsia. An alternative approach to screening for preeclampsia is to use Bayes' theorem to combine the a priori risk from maternal factors with results of various biomarkers. On the basis of Bayes' theorem, a competing risk model, which is based on a survival time model for the gestational age of delivery with preeclampsia, has been developed. This approach assumes that if the pregnancy were to continue indefinitely, all women would experience preeclampsia. And whether they do so or not before a specified gestational age depends on the competition between delivery before or after the development of preeclampsia. The effect of variables from maternal characteristics and history is to modify the mean of the distribution of gestational age of delivery with preeclampsia so that in pregnancy at low risk of preeclampsia, the gestational age distribution is shifted to the right, with the implication that in most pregnancies, delivery occurs before the development of preeclampsia, as you can see in this blue curve. In high-risk pregnancies, the distribution is shifted to the left, and the smaller the mean gestational age of delivery, the higher the risk of preeclampsia. Maternal factors have formed the basis of the competing risk model. We need to improve the performance of screening by adding a series of biomarkers. Through our research of the past 15 years, we have identified 3 biomarkers that are predictive of preeclampsia: uterine artery pulsatility index, mean arterial pressure, and serum placental growth factor. Here I show you the scatter plots of the MOM values of these biomarkers of preeclampsia cases plotted against the gestational age of delivery for preeclampsia. Both biophysical markers have a negative correlation with gestational age at delivery for preeclampsia, whilst the placental growth factor has a positive correlation with the gestational age at delivery for preeclampsia. The competing risks approach takes into account the effect of biomarkers according to the severity of the disease. The advantage of the competing risk approach is that it allows the assessment of individual patient risks of preeclampsia that require delivery before a specified gestation. In addition, Bayes' theorem provides a natural framework for dynamic prediction in which risk assessment is updated as new information becomes available during pregnancy. Incorporation of biomarker information using likelihoods means that new markers can be added by extending an existing model rather than developing a completely new model. Lastly, this approach takes into account the increasing effect of biomarkers with severity of preeclampsia. The first trimester combined test of maternal factors, uterine artery Doppler, mean arterial pressure, and serum placental growth factor, achieves excellent prediction for early onset preeclampsia with detection rate of 90% at a false positive rate of 10%. The detection rates for preterm and term preeclampsia are 75% and 45% respectively. This slide shows the different combinations of biomarkers and the detection rates at fixed false positive rate of 10%. As you can see, the best combination is blood pressure, uterine artery Doppler, and placental growth factor, achieving detection rate for early onset preeclampsia at 90% and preterm preeclampsia 75%. Nonetheless, you can refer to the other combinations, and if you add blood pressure on top of maternal factors, you can already improve the detection by about 8% for the prediction of early preeclampsia and 6% for preterm preeclampsia. I'm sure we'll have a little discussion regarding this mini combined test, which doesn't cost a penny. Further supportive evidence from the latest UK NIHR-funded SPREE study has shown that the first trimester combined test doubles the performance of screening for early and preterm preeclampsia and even term preeclampsia, as shown by the blue bars, in comparison to pink bars of the traditional method endorsed by NICE. I would like to introduce the concept of calibration. Calibration refers to how well the predictions from the model agree with the observed outcomes. Good calibration means that the predicted risk is close to the observed incidence. So if we have a predicted risk of 1 in 100, the observed incidence should be 1% too. Here I show you 3 calibration curves based on the training dataset of the retrospective data used to develop the model. Then we validated the model in 2 independent prospective datasets. The first is the ASPRE screening data, and the second is the UK-based validation study SPREE. You can see that the calibration curves are close to the expected curve in all 3 datasets. An important question that I'm asked often: what to do when a woman with risk factors is screened low risk by the first trimester triple test? This question has inspired me to conduct this study. During the screening quality study, we had 8,770 women and 59 subsequently developed preeclampsia. And during the second phase, we had 25,000 women screened and 159 women developed preeclampsia. So a total of 34,000 singleton pregnancies are included in this study. If a woman has one or more ACOG risk factor, then her chance of having preterm preeclampsia is near 1%, which is higher than the background risk of 0.7%. If a woman is doubly positive, she's screened positive by the ACOG guidelines as well as the FMF triple test, then her risk of developing preterm preeclampsia is substantially increased to 4.8%. But if a woman is ACOG positive and now she's screened negative by our method, her risk is substantially reduced to 0.25%, which is substantially lower than 0.7%, and that corresponds to a relative reduction of 0.05. So how about for NICE guidelines? If a woman is screened positive by NICE guidelines based on the high risk factor, then her chance of having preterm preeclampsia is 5.2%. And if she's doubly positive by both NICE and FMF screening method, then her risk of developing preterm preeclampsia is 8.7%. When she's screened negative by the FMF method, then her risk is substantially reduced to 0.65%, which is below that of the background risk. And this risk is corresponding to a relative reduction of 0.08. If a woman has moderate risk factors, then her chance of developing preterm preeclampsia is 1.7%, which is still higher than the background risk of 0.7%. And now she's screened positive by both methods, her risk is increased to 4.8%. And if she's screened negative by the FMF method, her risk is substantially reduced to 0.4%. And that corresponds to a relative reduction of 0.09. So in my opinion, if a woman has known risk factors determined by ACOG or NICE, but she's screened negative by the triple test, by the FMF triple test, I'll be very confident not to give her aspirin. So let's take a look at individual risk factor, because you might be interested in that. Taking a woman with a prior history of preeclampsia, having been screened negative by the FMF model, now her risk is substantially reduced from 8.1% to 0.67%. As for chronic hypertension, her risk is reduced from 13% down to 1%. For diabetes, her risk is reduced from 9.7% to 1.3%. As for systemic lupus, as well as antiphospholipid syndrome, her risk is reduced from 10% down to 0%. And now taking a look at the moderate risk factors, the softer risk factors, the woman's risk is substantially reduced from 4% to 5% down to 0.17% down to 0.5%. So I would be very confident not to give aspirin to a ACOG or NICE positive woman and now FMF negative. Again, another question has inspired this work. Can you simply start a triple test with uterine Doppler, mean arterial pressure, and serum PAPP-A, as PAPP-A is already measured routinely for Down syndrome screening? The simple answer is, of course, yes. But I would like to draw your attention to a recent publication from the FMF that focused on comparing the screening performance of PAPP-A and PLGF. For the prediction of preterm preeclampsia, you can see that when PLGF was added to maternal factors, or a combination of maternal factors with biophysical markers, the detection rates were significantly higher by 12 and 7% respectively. Similarly, for the prediction of early preeclampsia, you can see that when PLGF was added to maternal factors, or a combination of maternal factors with biophysical markers, the detection rates were significantly higher by 12% and 6% respectively. So the conclusion here is that PLGF is indeed superior to PAPP-A for the prediction of preeclampsia. But if money is an issue, it is a good start to utilize the the already measured PAPP-A first, and with time, it might be possible for you to introduce PLGF as part of the triple test. Many of you have asked if the FMF model would work elsewhere. At this point, I would like to draw your attention to several key factors that could affect the screening performance of the prediction model. The first point relates to the disease itself, the prevalence as well as the characteristics of the populations. The second point relates to biomarker variations, such as the physiologic variation as observed in the measurement of blood pressure. So we recommend not to use a single measurement as part of the prediction model. Instrument variability as observed in the measurement of placental growth factor. Inter- and intra-observer variability as observed in the measurement of uterine artery Doppler. So it is critical to be compliant with the well-defined measurement protocols. We were curious to find out if the FMF triple test works in Asia. In this study, we aimed to evaluate first trimester screening for preterm preeclampsia in several Asian populations. It was a prospective, non-intervention, multi-center study. Eligible women with singleton pregnancies attending for their routine hospital visit at 11-13 weeks of gestation were recruited from 11 centers from China, Hong Kong, India, Japan, Singapore, Taiwan, and Thailand. Maternal factors were recorded. Mean arterial pressure, uterine artery pulsatility index were measured according to standardized protocols, and concentrations of serum placental growth factor were measured by either one of the 3 commercially available analyzers. Let me remind you the protocol for the measurement of uterine artery pulsatility index. We advocate for the use of transabdominal ultrasound. You need to place the probe longitudinally over the suprapubic area to identify the sagittal section of the cervix. Fixing the probe in the midline, you turn on color flow mapping. Then you tilt the transducer to the side very slowly, because the cervix is actually a very small structure at 11-13 weeks of gestation. And if you tilt the probe very fast, then you might miss the uterine arteries. With color flow mapping, you should be able to visualize the arteries at the level of the internal os, as shown in this picture. Using the sampling gate of 2 millimeters to cover the whole vessel, ensuring the angle of inclination of less than 30 degrees, you capture the uterine artery pulsatility index. You can see the waveform. You need to ensure the peak systolic velocity is greater than 60 centimeters per second, because any values less than 60 centimeters per second, then you might be sampling the collateral vessels. You measure the left and the right uterine arteries, then the calculator will take an average of the two and will use the mean pulsatility index for the risk assessment. Here is the protocol for the measurement of mean arterial pressure. We advocate for the use of validated, automated, and even semi-automated devices. The woman must be rested for at least 5 minutes. The arms should be supported at the level of the heart. And then there are some chairs that you can allow the women to rest their arms on those armrests. So the women should not be holding their arms with their muscle. You must use the right size cuff, either small, normal, or large size, depending on the mid-arm circumference. You should measure blood pressure in both arms simultaneously, once and twice. So altogether you have 4 measurements, and the risk calculator will take an average of all 4. You'll find that taking blood pressure in both arms simultaneously really doesn't take you more time than necessary. It takes no more than 3 minutes. So I think it is extremely important that you comply with these very well-established protocols for the measurement of biomarkers in order to maintain good screening performance. Before we evaluated the screening performance of the FMF triple test in Asia, we wanted to evaluate the applicability of the European-derived biomarker MUM formula and perform a quality assurance assessment of the biomarker measurements. In this study, we utilized 2 assessment tools. The first was the target plot which allowed us to visualize the variations of biomarker MOM values and their dispersion, standard deviation. The second was the QSUM test, which allowed us to identify systematic measurement deviation from expected measurement distributions over time. You can see here are the target plots of the 3 biomarkers. The different symbols represent different recruiting sites, and each symbol represents 100 measurement per site. On the left, you can see that the MAP MOMs were well within the 10% of the expected median and standard deviations. The MAP tended to be lower in Asian women, however. In the middle, you can see that the majority of the uterine artery pulsatility index MOMs were well within the box of 10% limit of expected median and standard deviations. And on the right, you can see that the POGF MOMs were shifted to the left, except one site, having values shifted to the right. The findings of MAP and POGF suggested that there were systematic deviations in Asian women when compared with the Europeans. Here you can see are the QSUM plots of the 3 biomarkers. On the left, you can see that the MAP MOMs consistently shifted down. As for the uterine artery pulsatility index MOMs, except for one site, the values were well within the limits. And for POGF MOMs, the values consistently shifted down except for one site. This paper has demonstrated that, other than for quality assessment, the target plots and QSUM plots can also be used to evaluate variations of biomarker MOM values in comparison with European data. Here I show you the scatter plots of the MOM values of the 3 biomarkers against gestational age at delivery with preeclampsia. The reference line crosses 1 on the y-axis and represent the median MOM values of the normotensive cases. There are 2 regression lines as shown. The blue ones represent the relationship of the MOM values of the biomarkers against gestational age of delivery in cases of preeclampsia from the FMF, whilst the pink ones represent the relationship of the MOM values of biomarkers against gestational age of delivery in cases of preeclampsia from our series. Our regression line for mean arterial pressure was steeper than that of the FMF, whilst the opposite was true for uterine artery pulsatility index, suggesting that the MAP worked better in Asians than the uterine artery pulsatility index. As for the placental growth factor, the regression lines from both series were similar, suggesting that POGF is equally good for both populations. In the Asian study, calibration of risks for preeclampsia were generally good, with the area under the curve of 0.85 and calibration curve and calibration slope was 0.87, which is close to 1. As an example, the observed incidence of preeclampsia was consistent with the predicted one. When you give a risk of 1 in 100, the observed incidence is more or less 1 in 100, as you can see in this calibration curve. So here are the results on screening performance. In a total screened population of 10,935 pregnancies, we had an incidence of preterm preeclampsia of 0.7%, which was in keeping with the published literature. In this cohort, 97% of women were East Asian, and 4% took aspirin prophylaxis based on known risk factors for preeclampsia. Fixing the false positive rate of 10%, corresponding to a risk cutoff of 1 in 93, the detection rate was 62%. At a fixed false positive rate of 20%, at a corresponding risk of 1 in 193, the detection rate was 75%. Now, let's take a look at data from the FMF. Fixing a risk cutoff of 1 in 100, there are clear differences in the performance of screening between racial groups. In white women, the false positive rate was 10%, with detection rate of 69%. In Black women, the false positive rate was 34%, and the detection rate was 100%, whilst in East Asians, the false positive rate was 11% and the detection rate was 50%. Fixing the false positive rate at 10%, the detection rate was 50%, whilst fixing the false positive rate at 20%, the detection rate was 75%. So the graph in the middle schematically compares the results between the FMF and our cohort. We've decided that it would still be better to keep our risk of 1 in 100 for being the cutoff to define high risk, because I think that is a pragmatic decision. If I need to remember 1 in 93, I think that's a little bit difficult. So I think it is still acceptable for us to go for a risk of 1 in 100 to define screen positivity. We were also interested to find out how the NICE and ACOG approaches to screening would fare in Asia. Comparing the FMF triple test against the ACOG approach, we had to fix the false positive rate at 20%. And you can see that the detection rate of the triple test by the FMF was superior to that of the ACOG. The 95% confidence intervals did not cross. When we compared the FMF triple test against the NICE approach, we had to fix the false positive rate at 5%. And you can see that the detection rate of the FMF triple test was again superior to that of NICE. The conclusion of our work is that the FMF triple test is superior to the ACOG and NICE recommendations. So the FMF prediction algorithms have been validated in many parts of the world. In clinical medicine, number needed to screen is a tool for measuring screening benefit. According to the ASPRE data, the number needed to screen to prevent 1 case of all preterm and early preeclampsia are 143, 250, and 400 respectively. The number needed to screen for preterm preeclampsia is equivalent to the number needed to screen for the prevention of 1 case of early infection due to GBS through universal screening at 35 weeks of gestation. Compared to screening tools in clinical oncology, this number is far lower. The number needed to screen for the prevention of 1 case of breast cancer by mammography, lung cancer with CT, colon cancer with colonoscopy, prostate cancer with PSA, and cervical cancer with PAPP smear and HPV screening. So I think it is really time for us to acknowledge that we must screen for early onset preeclampsia requiring preterm delivery, because we have an effective method of prevention. So let's move on and discuss around preeclampsia prevention. Aspirin has a very long history. It dates back to 1500 BC, when the Egyptians used the extracts from the willow tree for pain relief. And many, many years later, Crandon and Isherwood in 1979 observed that in leprous women that regularly took aspirin, the incidence of preeclampsia was lower. Subsequently, many trials have evaluated the efficacy of aspirin in the prevention of preeclampsia. I'm sure almost all of you are familiar with the ASPRE trial, which has demonstrated that by giving aspirin at 150 milligrams nightly from 11 to 14 weeks to high-risk women identified by the FMF combined screening, the rate of early and preeclampsia can be substantially reduced by 80 and 60% respectively. As for term preeclampsia, you can see that this first trimester screen and prevent strategy does not have any impact. What is unclear to us is whether aspirin truly stops early onset preeclampsia from happening, or whether aspirin reduces the severity of the disease, leading to a delay in onset and therefore delivery. The diagram on the left shows the distribution of gestational age of delivery with preeclampsia in the placebo and aspirin groups in the ASPRE trial. This diagram demonstrates that in the aspirin group, the incidence of early deliveries with preeclampsia was indeed reduced. In addition, aspirin appears to have the effect in delaying the gestational age of delivery with preeclampsia. According to the diagram on the right, the aspirin-related delay is greater for early than later preeclampsia. So if a woman is destined to develop severe preeclampsia requiring very early delivery, it seems that the benefit of aspirin is at its greatest. We learned that the treatment effect size of aspirin was not affected by known risk factors of preeclampsia, except for chronic hypertension. You can see that women with chronic hypertension did not benefit from aspirin. We also learned that the importance of drug compliance would have an impact on the treatment effect size of aspirin. At any level of drug compliance, the rate of preterm preeclampsia is reduced by 62%. If a woman is very compliant, taking 90% or more of all tablets between 12 and 36 weeks of gestation, then we can see a greater reduction as 76%. In women, in high-risk women without a history of chronic hypertension, it seems that a high level of compliance could potentially reduce the rate of preterm preeclampsia by as high as 95%. So this is a very important message for your high-risk women. They would ask you what they should do. Should they be bedbound? Should they take a certain diet to minimize their risk? But you must tell them that none of those lifestyle modifications will work. They must take the aspirin religiously every day from 12 weeks till 36 weeks in order to achieve the best result from aspirin prophylaxis. Some of you are anxious about the use of 150 milligrams of aspirin. This slide summarizes the risks associated with aspirin during the ASPIRATE trial. You can see that the rate of serious adverse events was not significantly different between the aspirin and placebo arms. Regarding the risk of fetal defects, again, the rates were not significantly different between the two groups. Most importantly, the rates of renal or cardiac abnormalities were not different between the two groups. So I think you can prescribe 150 milligrams of aspirin to high-risk women with certain reassurance that it does not increase the risk of fetal anomalies. Preterm preeclampsia is a significant financial burden, as Dr. Ashok has already mentioned, because of the need of medical care required for the very preterm neonates. As shown in the ASPIRATE trial, that the proposed screen and prevent strategy reduces the cumulative length of stay in NICU by 68%. So this will inevitably lead to financial gain. If not, it would at least be cost neutral to the healthcare system. What is more is that we all know the consequences of preterm birth. Children born extremely preterm are at a substantial risk of death and disabilities, in particular cerebral palsy. In the long term, there's a high risk of impaired work capacity. So we must do our part in reducing the risk and therefore the occurrence of preterm deliveries. A recent publication from a Canadian group on health economic analysis has demonstrated that the ASPIRATE approach to screening and preventing preterm preeclampsia is associated with a significant cost saving of 14 million Canadian dollars per year, which is equivalent to 10 million USD. Such evidence further strengthens the argument for better screening and prevention of the disorder. Last year, our screening and prevention approach was endorsed by FIGO, recommending that published algorithms should be used for converting the measured values of mean arterial pressure, placental growth factor, usual natural pulsatility index, and PAPP-A into MOMS. Patient-specific risk for preterm preeclampsia is calculated using the Bayes theorem-based method, which is available as a risk calculator online in medical data software and mobile app. A woman is considered high risk when the risk is 1 in 100 or higher based on the first trimester combined test. And in Asia, will follow this risk cutoff, as I have already mentioned. And following the risk assessment in the first trimester of pregnancy for preterm preeclampsia, women identified as high risk, she is recommended to commence aspirin prophylaxis at 11 to 14 plus 6 weeks of gestation at a dosage of around 150 milligrams to be taken every night until either 36 weeks when delivery occurs or when preeclampsia is diagnosed. Low-dose aspirin should not be given to all pregnant women. This is a very important message. At this point, I would like to make reference to a very recent publication from the St. George's Group. They pragmatically implemented the first trimester multi-marker screening with PAPP-A instead of PLGF. They gave 150 milligrams of aspirin prophylaxis to high-risk women with a risk of 1 in 50 or higher in order to maintain a screen positive rate of 10%. High-risk women followed the high surveillance pathway and were induced at 40 weeks. The authors compared the rates of preeclampsia between the implementation phase and a historical cohort and found that the rate of preeclampsia was significantly reduced by nearly 30%. They then performed an interrupted time series analysis and found that, in fact, the rate of preterm preeclampsia was reduced by 80%. The conclusion from this study is that first trimester multimodal screening for preeclampsia with aspirin prophylaxis is feasible and effective in a public health setting. Now, I would like to share with you the patient trail for preeclampsia screening at my unit at Prince of Wales Hospital at the Chinese University of Hong Kong. We have set up a corner in our observation room for blood pressure measurements that would allow both arms to be measured. Women check in at the reception, then we transfer the woman to the observation room for height and weight measurement by the healthcare assistant. The blood pressure is also measured by the healthcare assistant. Then the woman will go for clocking and consenting for screening by the nurse, followed by ultrasound by one of us. Then we send the woman for blood draw by the phlebotomist. And here I show you a picture of our group counseling in our clinic. So we have found that group counseling is most effective. So we'll tell women what it means to be identified as a high risk for preeclampsia. We teach them how to take aspirin. We show them a drug diary that they need to fill out and to ensure compliance, etc. And here are examples of reports that we can generate. And this report on the left demonstrates the risk of a low-risk woman. We collect data on maternal factors according to the FMF guidelines, and we measure blood pressure, uterine artery Doppler, and placental growth factor. We have also generated normal ranges based on the circumstances of the woman, so every graph will look different. You can tell the differences between the two reports. So each normal range for each biomarker is individualized. And so this is a graph for blood pressure, and this is for uterine artery Doppler, and this is for placental growth factor. So and the dots are well within normal range, and her adjusted risk is 1 in 679. On the right, you can see a report belonging to a high-risk woman. She is basically in her first pregnancy, and her background risk was low risk, 1 in 168. She's had her blood pressure checked with a mum of 1 in 1.18, and her uterine artery Doppler is raised with a mum of 1 in 1.28, and her PLGF is reduced at 0.71. So you can see that on these graphs, the blood pressure is a little bit raised, the uterine artery pulsatility index was a bit raised, and the PLGF was lower. And so her adjusted risk for preterm preeclampsia was high risk at 1 in 42. To finalize, let me refer to the number needed to treat to prevent 1 case of preterm preeclampsia. Based on the data from the aspirin trial, the number needed to treat for 1 high-risk woman is 38, which is a very respectable number. This number needed to treat increases to 69 when our focus is on early onset preeclampsia requiring delivery before 37 weeks. As for preventing small babies, the numbers needed to treat range from 16 to 30. For perinatal death, the number needed to treat is 34. Based on these numbers, again, is a no-brainer that we must really start preventing preeclampsia by the use of appropriately dosed aspirin given to high-risk women. When you are planning to implement the first trimester Screen and Prevent program, here are your considerations. Existing infrastructure for early pregnancy screening. So of course, in our setting, we are rather lucky. We have an existing infrastructure for Down syndrome screening. And therefore, we can piggyback the preeclampsia screening on top of the Down syndrome screening, and we were able to introduce this within months on my arrival. We need to know the background risk in your population based on maternal factors, and you need to know the adherence to the existing screening strategy because it would dictate how much education you need to provide for your colleagues, healthcare providers, and patients. There should be standardization of protocols for the measurement of biomarkers. There should be a process of training, quality assurance. You also need to recognize the potential differences in values of biological parameters, as you have observed in our data in Asia. You need to work out the logistics of implementing a Screen and Prevent program. There need to be pre-test and post-test counseling, as you have seen from my pictures. You also need to decide if you were to opt for the full combined test, if financially feasible, or whether you need to go for a variations of the combined test, be it maternal factors with blood pressure as the baseline, or you are able to add on PAPP-A because that is already measured as part of the Down syndrome screening. And you can recognize that history with blood pressure or history with blood pressure and PAPP-A induces no additional cost. You also need to know what preparations of aspirin tablets you have, because in some countries, I have learned that they only have 300 milligrams, so they need to halve the tablet. But you need to bear in mind that when you halve the tablet, the other half must be discarded because once the active ingredients of the tablet is exposed to water, then the active ingredients are inactivated. And if you are in a setting whereby you only have 75 milligrams, you need to double the dosage, or 80 milligrams, you need to double the dosage. And if you have 300 milligrams, as I mentioned, you can simply halve it, which is very convenient for you and the patients. In Asia, we are doing what we can to implement the FIGO guidelines on preeclampsia prevention. And I'm very grateful to all my friends and collaborators who continue to support such an important cause. So here's the end of my talk, and I'll be happy to take questions now or later, or as part of the panel discussion. Thank you for your attention.
Thank you, Liona, for this absolutely excellent presentation on what we need to do and how we need to do this. We've had a fair number of questions coming up in the chat box, and we have time for those. And the first question that has come up is very simple. What's the risk of giving aspirin to every woman who is pregnant? Just like that.
Thank you for this very, very important question, because I'm asked almost every time I give a talk on this topic. There are several issues with regard to aspirin for everybody. Please bear in mind that aspirin isn't Smarties, it isn't M&Ms, it isn't a vitamin, it is indeed a drug that is known to cause significant side effects such as upper GI symptoms, upper GI bleed, as well as intracranial bleed. It is very clear, based on non-pregnant data, that if a patient is taking aspirin, he or she is at a 5-fold increase in risk in having intracranial bleed and in an upper GI bleed. So if you start giving every pregnant woman in the world aspirin at 150 milligrams, I think we'll be doing more harm than good. That's one fact. Second, pregnant women don't like taking medications, and I'm sure you would agree with me. If I don't tell a pregnant woman that she is indeed high risk of developing preeclampsia, the chance of compliance is extremely poor. Do you know what the compliance is for folic acid? Folic acid is only a supplement, and you tell them that they will prevent spina bifida. Compliance is only at 40 to 50%, and that is also true for multivitamins, let alone aspirin. And you need to understand that women who would then take aspirin religiously, although are those that are highly educated, wealthy. They don't need aspirin because they would be falling within the low risk group. For those who would absolutely need aspirin are the deprived women of low socioeconomic class. They're not going to listen to you until you tell them that they are high risk. So the trouble with giving aspirin to everyone will not be targeting the really, really at-risk group. So I think we must provide screening for those who are absolutely in need of aspirin. And the last point to illustrate is that if we take 1,000 women, the occurrence of preterm preeclampsia within these 1,000 women is 3. In order to prevent these 3 cases of preterm preeclampsia, I'm going to subject 990 women to aspirin unnecessarily. Ask yourself, is it ethical? Is it the right thing to do? So I think it is absolutely important not to give aspirin to everyone. There might be circumstances that this is the only way forward, but certainly not in countries whereby you'll be able to take a decent history and to measure blood pressure. And in those places where you do provide Down syndrome screening with PAPP-A, you can simply borrow the PAPP-A from Down screening and add it on and provide the mini double test.
Thank you for that very nice, straightforward consideration. And then we have 3 related questions. And the first is that in the screening for trisomy 21 in the first trimester, does PLGF do as well as PAPP-A, which means should we dispense with PAPP-A and just to the PLGF? And what would we be compromising on in case we do that? And then the second question is, does PLGF improve the screening for trisomy 21? And the third one is, can PAPP-A replace PLGF for a preeclampsia screen?
Thank you. I hope I remember. I mean, there are different bits in this question. So based on our recent data in Asia, we have demonstrated is actually a publication under consideration right now. We have actually shown that PLGF doesn't improve Down syndrome screening, which is already provided by HCG and PAPP-A. But nonetheless, if you choose to provide preeclampsia screening with PLGF, then that can also be incorporated for the Down syndrome screening. And I think the FMF has shown slightly better detection with the use of PLGF for Down syndrome screening. So I think there's a straightforward answer for this question. I think it is still important to look at your data to see whether the addition of PLGF would improve the Down syndrome screening. But I think if I were to consider swapping PLGF with PAPP-A, then I would do that. And sadly, I will not be using PAPP-A within my algorithm because PAPP-A is very, very related, I mean, it's closely related to PLGF and therefore becomes redundant as part of the Down syndrome screening, as well as PLGF, as well as preeclampsia screening. But if money is an issue, which is, I am sure, in many parts of the world, then I wouldn't urge you to swap PAPP-A for PLGF. I would urge you to use PAPP-A as part of Downs and preeclampsia screening, because it comes with no additional cost at this stage, if PAPP-A is already provided and it is obviously cheaper.
Yes, so a compromise will always be a compromise. And why should we start with a compromise? Yes. The next question is, could you please repeat for some of the beginners what we mean by the FMF triple test compared to our nice old-fashioned triple test of the 1980s? You know, our second
so
trimester.
the FMF triple test for preeclampsia is basically adding mean arterial pressure, uterine artery pulsatility index, and serum placental growth factor with maternal factors. So the 1980s triple test is basically the serum biochemistry for Down syndrome. So I know it is a bit confusing, but then we've decided that it's extremely difficult to always mention blood pressure, uterine artery Doppler, and placental growth factor. So we could always say that the FMF preeclampsia triple test. That might make it simple for you.
Thank you. And the next question is, any tips for enhancing compliance in our patients?
For aspirin prophylaxis,
Yes.
I think giving them the figures, you tell them, if you take aspirin at any level of compliance, you'll be able to reduce your risk by 60%. But in the absence of chronic hypertension, you might be able to reduce your risk by up to 90%. That is a very convincing number. So I think with that, any woman would listen. And I would suggest to you to ask the woman to bring out her mobile phone. So when a woman attends our high-risk clinic, so you saw the picture of a group counseling. So at that moment, my nurse would ask the woman to bring out her mobile phone, and she would set an alarm. And the husband as well, alarm at 10 o'clock every night. That will go off every night to remind the woman to take aspirin prophylaxis. And it really works.
Thank you. Does aspirin reduce the rate of superimposed preeclampsia in chronic hypertensives?
Well, based on our data, it seems that aspirin doesn't have an impact on high-risk women with chronic hypertension. So, but at this moment, I'm not saying that you mustn't give aspirin to women with chronic hypertension, because obviously chronic hypertension is indeed a major risk factor for preeclampsia. So I think the woman must be fully counseled that aspirin might not have an impact. And on that basis, if a woman still chooses to take aspirin prophylaxis because chronic hypertension is such a significant risk factor, then I wouldn't discourage her to do so. But the woman must be fully informed that there's a possibility that we might not achieve any beneficial effects from aspirin prophylaxis.
Thank you. We only have 92 questions left, but let me pile them up together.
Dear.
The influence of aspirin on preterm delivery.
So I think in our data, we did not demonstrate a rate of reduction for spontaneous preterm delivery, but indeed there was an overall reduction for any preterm delivery as a result of the reduction of preeclampsia rate.
And the next question is on aspirin and body weight. Would titrating the dose by body weight be a better idea than 150 milligrams?
Well, that's a very good question. Right now, within the FIGO guidelines, we have advocated for the use of 150 milligrams for anybody with a weight of 40 kilograms or higher. Anybody with a weight of less than 40 kilograms, we recommend a dosage of 100 milligrams. Titrating dosage sounds like a very, very good idea, but that will only complicate the matter. I think the minimum dosage that we need to achieve good result is around about 2.5 to 3 milligrams per kilograms. So that is more or less 150 milligrams for an average pregnant woman. So I think let's stick with 150 milligrams.
Wonderful. And then we need tips on locating the uterine artery during a first trimester screen.
Thank you. Very important. As I already mentioned, that the cervix is a very small structure in the first trimester pregnancy. So when you put the probe over the suprapubic area, you visualize the sagittal section of the cervix. You need to basically turn on color flow mapping and fixing the probe in the midline very, very slowly. You tilt the probe, not sliding. Don't slide the probe. You need to tilt the probe to the sides of the cervix, and very slowly the color flow signal would show. And because it takes a bit of time for the color Doppler signal to show, you need to do that very slowly. And 99% of the time, I'll be able to visualize the uterine arteries at the level of the internal os. And we are right now preparing a series of videos for demonstrating the tips and tricks for the measurements of uterine artery Doppler, blood pressure, and the lab side of things. So do watch this space, and hopefully we'll be able to show you these videos in a couple of months' time.
Well, wonderful. We'll do a workshop on that for ourselves. Thank you. There is this question on the cutoff of uterine artery PI. Which figure should I use?
There is no cutoff, as I already mentioned in my slide when I demonstrated the two reports, because every single uterine artery pulsatility index is individualized for a patient. We know that the PI is influenced by various maternal characteristics, weight and height, parity, ethnicity, and so forth. And therefore, every woman would actually have her own reference range. And the key is not to go with the risk cut, not to go with a mom cutoff. We need to measure the biomarkers, combine the biomarkers with the maternal risk factors, and then look at the final adjusted risk. And to determine if a woman is high risk, you go for a risk cutoff of 1 in 100 or higher.
No halfway tricks.
No.
And then therefore, can we take only 2 values of the blood pressure in one arm for mean arterial pressure?
So ideally, we would recommend the full protocol, as I mentioned, both arms. So you need 2 machines, and the machines that we use are affordable, $15. I mean, perhaps that's still considered to be expensive, but I'm happy for you to contact me so that we can get a better deal. And I don't have any shares, just for you to know. Measuring blood pressure in both arms is better. But if you tell me that you can't afford to buy a second device, then you measure blood pressure in one arm twice. That is our pragmatic protocol defined in the FIGO guidelines.
Our blood pressure machines are 1/4 the cost of yours, so I don't see any reason in compromising on that one. Now, we also have question on starting aspirin after 16 weeks and starting aspirin at the time of screening the uterine artery at 20 weeks. How much should we do it, should we not?
Obviously, if a woman was 16 plus 2 weeks, and sadly, she's obviously a little bit too late, but equally, I think we must explain clearly to the patients. I mean, first of all, you wouldn't have done the first trimester screening, but maybe you have done the first trimester screening, but then you were not able to reach out to her for whatever reason. You couldn't reach out to her before 15 weeks for her to start aspirin. In the end, you found her at 16 weeks. You need to explain to her that she missed the boat. However, based on the ASCII, based on the Bujold meta-analysis, starting aspirin after 16 weeks shows a non-significant 20% reduction. So you have to tell this woman, there might be this 20% reduction, but we don't know whether it would really work. And because there are side effects with aspirin, and it is really entirely up to the woman to decide whether she would consider taking aspirin. And at 20 weeks, I think the counseling should be more or less similar. But I think it is really too late. In my opinion, 16 weeks plus 1-2, missed the boat, but perhaps there might still be some benefit. But by 20 weeks, presentation is over. It really, I would think, is really too late.
Thank you. And what about screening and aspirin in twins?
I think based on Kipros's work, indeed we can screen preeclampsia in twins at very, very high detection rates, but at a very high false positive rate too. So for now, I would think that it might be more sensible to just treat twinning as a risk factor and consider giving aspirin prophylaxis at 150 milligrams for all twins. It is a pragmatic recommendation within the fetal guidelines. But we're waiting for more high quality data from Kipros, as you know. He's doing a massive trial again.
A question also on the vaginal evaluation versus the transabdominal evaluation for the uterine artery Doppler, and how much does this have a bearing on risk assessment?
So I want you to bear in mind that all the work done at King's and by the FMF is based on transabdominal approach. So all the risk calculators, all the screening performance are based on a transabdominal approach. Yes, it is possible to measure uterine artery pulsatility index by the transvaginal route, but we have also learned that although the measurements by both approaches are comparable, but when the uterine artery PI is on the high end by the transabdominal approach, then there seems to be an underestimation by the transvaginal approach, which could potentially lead to a false negative case. So I think you need to bear in mind. And if you've done the transvaginal approach, you wouldn't necessarily know that is a high PR value transabdominally, then you would perhaps miss a high risk case.
And then we need a reiteration on the use of aspirin in chronic hypertension. Do we give it or do we not give it?
I think the answer is not straightforward. I don't think we must or mustn't give it. It is a process of counseling and a joint decision. If you have a high-risk woman with chronic hypertension, you need to tell the woman the evidence that aspirin might not work. And because chronic hypertension is such a significant risk factor for preeclampsia, so the woman is given the choice of taking the chance of not taking aspirin and taking a chance of taking aspirin, but she needs to bear the risk that there could be side effects and aspirin might not have prevented preeclampsia.
Yeah. And then
I cannot tell you you must give or you mustn't give, because this is not an easy answer. Yeah.
Yes. And in patients who are allergic to aspirin, any alternative?
Sadly, there isn't an alternative right now other than increasing awareness and high surveillance program and home blood pressure monitoring.
Thank you for that.
We do not recommend heparin. We do not recommend heparin.
And certainly not sildenafil. Yes. The next group of questions is on the follow-up. How much uterine artery Doppler at the time of the anomaly scan, repeating scans at 24 weeks, and then of course the FMF or the SFLT inclusive algorithms for later in pregnancy. What do we have? What kind of a follow-up should we give these patients?
Very good question. And I think this is going to be my focus in the next year or so, because right now, all the data from the FMF is based on aspirin naive patients. You know, even 20 weeks assessment, the 30 weeks assessment, 36 weeks assessment, you know, these assessments, performance results are based on aspirin naive women. So my work in the next year or so is really to understand what would happen to the biomarkers at later gestation in house women treated with aspirin. So for now, we don't recommend that if a woman is screened negative at 20 weeks, we stop aspirin. We don't recommend that because you must have read our opinion paper published in a white journal that a high-risk woman is a high-risk woman for the rest of the pregnancy. But then you would be able to tailor-make her management program according to the risk assessment at 20 weeks and 32 weeks.
So could you tell us a little more about this? There is a suggestion that we bring in all patients at 36 weeks to assess for for term preeclampsia.
Yeah,
so,
I think that would be a wise decision, because that visit is not just for preeclampsia assessment. It is a visit whereby you determine the fetal growth. You determine whether there is a non-cephalic presentation to advise on external cephalic version, and you determine the risk if the woman has preeclampsia. So I think it is a very important time point for providing a comprehensive risk assessment for a number of pregnancy complications. So at that time point, you would determine whether the woman needs early delivery at 37 weeks, or whether the woman can continue with the pregnancy without much of a hassle.
And that brings us to the question of my high-risk screens. Until the results of your further study come out, what kind of a clinical algorithm can I use for my high-risk patients once I'm past my 20-week scan?
Sure. So right now, our plan is to see these women. If a woman is high risk on aspirin, then we will see her at 24 weeks, 28 weeks for blood pressure check, and then a risk assessment at 32 weeks for fetal growth, blood pressure check, and if you can afford adding PLGF and SFLT to determine if a woman is likely to develop preterm preeclampsia, so that you'll be able to catch that in good time. And afterwards, you will see the woman at around 35, 37 weeks to determine timing of delivery.
Wonderful. That actually answers the next three questions that came in, but it gives us more time for this very interesting question, which is, in case the patient is bleeding in pregnancy, should I stop aspirin?
Very good question. Depends on the severity of bleeding. We know that aspirin doesn't cause bleeding. It might worsen bleeding. So if a woman has spotting, I would certainly assess the woman first and determine if there's a concern of placental abruption. If there's no placental abruption, then I would continue with the aspirin, warning the woman that yes, her bleeding might worsen, and by then we would consider stopping. The trouble with bleeding is that it is also a sign of poor placentation. It is also a sign that the placenta is not working well. So I think these women truly deserve to have aspirin. But if a woman has severe bleeding and that's her, she's bled 100 mils, 200 mils, and then yes, we will consider stopping aspirin for a week or two. And then once bleeding settles, then you will need to resume aspirin prophylaxis.
Wonderful. That actually completes our entire set of questions. And I'm shocked that we're actually running on time, except for one question that popped up suddenly. And it wants to make us dance to the notch again. The uterine artery notch. Would you please quickly throw it into the dustbin very loudly?
We don't use the notch as a screening tool because it is a categorical variable. We believe that the key is to measure the uterine artery pulsatility index. If there is a notch, then the PI would be measured high, and that is a more accurate way of providing risk assessment. A notch, yes, it tells you that, yes, perhaps it's high resistance, but you still need to measure the PI for you to tell me that this uterine artery value is, the Doppler value is high.
Thank you. And that actually completes our list of questions so far. And if there are any more, I promise to either email them to you, or unless you're staying on with us for the rest of the afternoon, that would be wonderful. I know it's late in Hong Kong and it's a Sunday, but feel free to stay with us, and that would be wonderful. Thank you so much for this very, very exciting presentation for telling us so clearly and plainly what we need to do, and also for clearly telling us what we need to do for a follow-up. Your question and answers were absolutely amazing. You're very, very kind. Thank you indeed.
Thank you, Ashok. Thank you. Thank you for everybody's attention, and lovely, really, really good is to get so many questions. And that means there's a lot of interest in this topic.
Thank you. And we now move on to the second part of our afternoon's program. And I hand over the floor back to Naveen for carrying this further.
Right, sir. Thank you so much. And this was indeed an enlightening talk by Dr. Liona, and that our 60 minutes just flew by. And I am we are all very, very happy to have her in the midst. And it was wonderful. The talk was wonderful. So many wonderful insights into pre-eclampsia, the prevention, the management, the detection. Thank you so much. And in the midst of this wonderful talk, I would like to announce our next program, the next quarterly meet of the Society of Fetal Medicine, the Ludhiana chapter, that would be in January, and that's about 2.5 months from now. And the topic would be on FGR, fetal growth retardation, and that would be an interesting protocol that we'll be having. We'll be having a couple of panel discussions, and those would be based on abstracts that we will be inviting from everyone on FGR. If anyone has an interesting case, they could send those abstracts to us. The last date for that would be the 15th of December. And those abstracts would be judged by a panel of experts. And out of them, a couple of them would be basically decided to be the abstracts that we would be having for a case-based panel discussion. And on that note, I would hand over the floor back to Khurana sir, and to conduct the next program, the case-based panel discussion in his very own inimitable style. Thank you, sir.
Thank you. Thank you, Naveen. And, I must tell you that this idea that Dr. Deepak Bansal and you have given us for actually opening up our presentations to proffered papers and abstracts is now going to be accepted nationwide by the Society of Fetal Medicine. We discussed it in our mentors group, and it's one of the most brilliant suggestions we have absolutely ever received. And it's truly fantastic that you came up with this, because now there are people whom you and me don't get to hear at all, and they will get a chance to present before us. Thank you indeed for that. And of course, my best wishes to Ludhiana. They've always been so active, and I'm really happy to see so much activity going on there. We move on to our next part of the program. And before that, I'd like to acknowledge the support we've got from our industry partners. And we have the slides here from them. We are grateful to GE for giving us support for this program. And we are also grateful to them for supporting us in some of our academic activities. And then also to LifeCell, who support us both for our pre-eclampsia screening as well as for our first trimester and later screening. They're also going to be able to make available SFLIT for us, and Dr. Lal, which is a household name in our part of the world, for making available collection centers and places that patients can get reports from any part of the world. Thank you very much. And we now move on to our actual panel discussion. And I'm going to request our panelists to join us. Do you see my screen now? Is my screen appropriately shared?
Yes, sir.
Yeah.
Wonderful.
I would request you to stop sharing, please.
Coming blank.
It's coming back. All right.
Yes,
so
let's see now.
Okay, so I will do that fresh again. And you'll have to give me a minute. This is always very exciting when I change over my screen on my dear old Mac. And I will do that again by opening that out and going through this. And you bear with me for 2 minutes, 1 minute, maybe half a minute, maybe. Yes, and I'm going to restart my screen share, and do let me know if it works. Do you see my slides at the moment?
You can
Yes,
see.
sir.
Yes,
Yeah.
yes, sir, we do.
When I go to full screen, are you still seeing this?
Yes, sir. Yeah.
Ah, wonderful. And then we're good to go. So let's start where we left off. And we've learned that we have an excellent way of predicting preeclampsia at 11 to 13 weeks. And there's no choice but to do this. It's taken us several years from 1991 to 2016 to master this. And we have one of the masters here with us today. And she's shown us how to do this. She's shown us how beautifully combining additional features will actually improve not only screening but outcomes as well. We've had an introduction to some of the biomarkers, and we hope that greater availability of these will help us take our next step. And importantly, this little thing here at the bottom here, telling us that in our NICU expenses, we're going to be able to cut them down hugely, and therein truly lies the National Equity Intervention Program. We've had some recent research into ophthalmic artery Doppler that we heard a little while ago from Kipros a few days ago, and we hope that becomes available because our ultrasound people are fairly good at helping us out with everything. And of course, the fact that we now even have this, which is our program for places with less resources or patients with less resources. And we have an option for them as well, which FIGO has suggested for us. And I thank Dr. Liona Poon for having put us through all of this and also for making this research available. She was a prime mover behind all this research, and we're really lucky to have her in our midst today. I have an illustrious set of panelists, and they're all from Ludhiana. We have Dr. Maneet Kaur, Dr. Gitanjali Kaur, Dr. Zini Gin, Dr. Satyajit Deo, Dr. Pradeep Sharma who's representing the pediatrics and neonatology. We have Dr. Ajay Agarwal, and of course, Naveen is going to be on this panel as well. And we're going to discuss 3 cases, and we're going to move from global to local to logical, which means that in our own circumstances, how would we ever handle something like this? So let's go with this, and remember that the audience can put in questions into the chat box, and we will answer them at the end of the panel discussion. We have a compartment for that. Put your questions in any time, and we will answer those. We try our best to cover everything. Our first case is that of a 24-year-old Faimi, and she presents at 6 weeks of pregnancy for her first medical check. She has a healthy background and no significant medical history. But apart from a concern for something she hears about a new test for assessing high blood pressure in pregnancy. So my first question for this entire thing goes out to Dr. Zini. How would you guide this patient?
Okay. Thank you, sir, for that question. Good afternoon to everyone. I think this patient, she's a young primate. My first thing, as Dr. Poon was also mentioning, and which is now recommended, is that I will do a screening from the history of this patient, which means that checking her body mass index. And you tell me that she doesn't have any significant medical history, but then I might ask some leading questions about any family history or anything like that. So there are a lot of guidance, the ACOG guidance, the FMF guidance, the NICE guidance, and now we even have in India the Gestosis score. So we can do the scoring, and then if she is at high risk, then advise her that what we probably plan to do is say around 11 to 13 weeks of pregnancy. We do an ultrasound scan where we do 2 things. One, we look for any increased risk of genetic disorders, so screening test for genetic disorders, which is your NT and NB scan. And along with that, we do some measurements in the blood and blood pressure. So at that time, we do the blood pressure measurements, you do the patient's ultrasound scan to check for the PI, And along with that, you send your test for PAPP-A and for beta HCG for dual marker, and if resources permit, then for PIGF to look for the screening, which can give us a predictor whether she is likely to develop high blood pressure in future in the pregnancy, and we can actually take some measures to try and prevent that.
Thank you. And my next question is for Dr. Satjit Deo. In addition, when we go through all of this, do you additionally sensitize your patients for screening for preeclampsia when you counsel them for trisomy 21 screening?
Hi, good afternoon, everyone. Yes, we do sensitize all our patients with singleton pregnancies for preeclampsia screening, in addition to aneuploidy screening. In fact, we have started including PLGF in our routine combined test for trisomy 21 screening. So whenever a patient comes for her first trimester scan, we routinely provide her a detailed counseling about this new first trimester screening model for the prediction of preeclampsia. Which includes, which has already been discussed by Dr. Poon. It includes the maternal characteristics and also the measurement of mean arterial pressure and the uterine artery PI and biomarkers like PLGF. And this test has a detection of about 90% with a false positive rate of 10%. And if the patient agrees to get this test and if her test comes as high risk, then we provide her with a post-test counseling regarding the use of aspirin 150 milligrams from 12-week onwards, which has been shown to decrease the risk of preeclampsia by about 60%. And in fact, this counseling is very important for both the patient as well as the clinician, as it can reduce the maternal morbidity and mortality associated with preeclampsia.
And how do you handle family pressures when they say this? Is aspirin, isn't that given to a heart patient? Does she have a heart problem?
Like usually, the patients who agree for this combined test, sometimes they ask these questions, but we just advise them and we tell them to discuss with their gynecologist also if it has to be started, and we tell them about the recent trial results, that it is not just for the heart patients. It has been shown and it has been proven that it helps in the reduction of preeclampsia.
Thank you. The next question for Dr. Gitanjali. What changes in attitude towards screening and prevention in pregnancy have you seen in your patients over the past 20 years? How do you manage time for counseling?
Good afternoon, everyone. First of all, I'll take on I will like to take the last question. Yes, patients do question about the aspirin because there's a warning written on that also, not to be taken in pregnancy. So we as gynecologists have to deal with that also. And I would really like the FOXY and the SFM to do something about that warning that is always written on the tablet, aspirin tablet. So we have to counsel for that also. And yes, we have to explain everything. About the change in attitude, yes, people with the increase in knowledge of the female with social media, with YouTube videos and everything, patients almost know about anti-scan and double marker. Most of them know about it. This patient which you have just talked about, yes, it's maybe it's the future, then the patient will come asking for a test for hypertension. And that will be really good. If the patient comes asking for it, it is always easy to counsel the patient. Because otherwise, with a lot of training sessions that have been done by FMS and integration of everything in a computer with risk calculations, it has become easier for us as gynecologists to counsel the patient. Because earlier there used to be so much discrepancy in the reports that ultimately we had to deal with the patient. If the hard step had to be taken, we had to take it. So we have to have full confidence in the reports and then advise an invasive test with the guidelines, with auditing of reports, with everything done down the line in our last 20 years, we are much more confident to explain to our patients that yes, this screening results means this, and yes, you have to go for an invasive test or not go for an invasive test. Another thing for counseling, Both pre and post-test counseling are equally important. I run a private practice, so I can, yes, spare time for this because I have my own private patients. For all my patients, I say, just as when you're making a house, you lay down the foundation, you put all the pipelines. Similarly, 12 weeks is the time when whole of the pipeline is being laid down for your baby. So it is at this time that we have some markers, we have some tests by which we can assess if there is something wrong in that pipeline, whether that will last till term, that is 40 weeks, or we might have to deliver you early, or there might be some risk factors that might come early in the pregnancy, or maybe you are carrying an abnormal baby. So all of this can be ascertained at 12 weeks by simple test, which includes a ultrasound, a detailed ultrasound study, and some blood markers. And usually patients respond well to that. Also, when you tell them that this test, which is available in Ludhiana, we have everything, all of these markers, 5 markers, triple test, along with the PAPP-A and a double marker test and the ultrasound. And I tell them you are getting best of the facilities as equivalent to anywhere in London, New York, and that convinces the patient to spend that amount of money. And post-test, yes, as Dr. Poon said, we are the one who will be looking after the patient. Patient will be coming back to us at each visit. So assuring a compliance of aspirin more than 90% in the high-risk patient is very important. And it is only when we do the post-test counseling to them, when we explain it to them that this is the medicine, a simple, cheap medicine, which will prevent, which will help you to and prevent so many complications in the future, so many heartburn in the future. Because most of the patients are very worried. Even the mother-in-laws, because in Ludhiana we have a lot of mother-in-law practice, Punjabi mother-in-law will always come along. And when blood pressure बढ़ जाता, doctor कह देते blood pressure बढ़ गया, doctor कहते हैं बच्चा कमजोर हो गया, इसके लिए बच्चा जल्दी निकालना पड़ रहा है. These are simple questions that they are always afraid about. So when you tell them that you have a test by which we can detect if the blood pressure can rise in the end, if the baby will remain weak for some reason or the other, the compliance toward taking aspirin is much more. So yes, it is very important to take out time because this is the time when you have to prime them for whole 9 months.
Wonderful. Thank you for that. Well, the patient goes ahead with routine tests in pregnancy and a first trimester screen, including a preeclampsia screen at 12 weeks. She's low risk. Her anomaly scan at 19 weeks is clear from a fetal morphology and growth perspective, but she shows a high impedance flow in both uterine arteries with a mean PI of 3.1. So the question then arises, at the anomaly scan window, and this question is for Dr. Naveen Pereira, do you routinely assess uterine artery PI?
Yes, sir, I do that. I've been doing that for a couple of years. And I would say that it is a good clinical practice to do that, despite the fact that it's probably not in the ISIOG anomaly protocol. But why I would do that is because it is, first of all, if you are doing a pre-eclampsia screening in the first trimester, it would be the continuation of a screening strategy, as we have discussed at the anomaly scan window. Firstly, and secondly, in our low resource settings like in our country, there would be many patients who would not have had this NT scan done, or then in that case too, that would be the first time that the patient would be coming to us. So in addition to the maternal blood pressure and the maternal history, I would want to go to assess the uterine artery PA. Yes, sir.
Wonderful. And the next question is for Dr. Ajay Agarwal, as well as I want Dr. Mani to answer this question both in their own way. What is your protocol? Routine inclusion of uterine artery PI at the 18 to 20 weeks, or you think it's a waste of time or patients regard it as big money? Dr. Ajay Agarwal first.
Good afternoon, sir. Yes, sir, I think we should include the uterine artery pulsatility index in all routine level 2 scans at 18 to 20 weeks. For the reasons that Dr. Naveen just mentioned. First of all, even if you have a screen negative in the 11 to 13 week scan, there might be certain patients who might become positive now. Up to 5% of the patients will have a screen positive at the 18 to 20 weeks ultrasound. Now, although we would have lost the opportunity to start aspirin, but still these patients could be kept on a high degree of surveillance and maybe blood pressure monitoring, or asked to go to tertiary level centers, and that would still be beneficial. So all 18 to 20 week ultrasound, we must continue with your uterine artery pulsatility index.
Thank you. And Dr. Manith, your opinion on this? Dr. Manith Kaur, your opinion on this? Have we lost connectivity with Dr. Manith?
Please, Manith, can you please unmute yourself?
Yes, yeah.
Thank you.
Yeah, I agree with what Dr. Ajay and Dr. Naveen has said. And I've been doing uterine artery PI since the last 4 years that I've been practicing. And one more thing that I would like to add is that we have to follow proper technique of doing the uterine artery PI. We must take care not to sample the arcuate arteries by mistake, so that we don't end up having false negative results, and we reassure the patient based on the low uterine artery PIs if they are not measured properly. And also uterine artery PIs as a standalone marker, they have a good predictive value for preterm preeclampsia if done at 20 weeks. It's around 80%.
Wonderful, thank you for that. And Dr. Zini, what next? Could you please let me know how you use information on reevaluation of this uterine artery, and how you would you request for a scan again at 22 to 24 weeks, low dose aspirin at this stage, and your plan for surveillance of this pregnancy? Dr. Zini?
Yeah, sorry, I've just unmuted myself again. Just as Dr. Ajay mentioned, that sometimes in early pregnancy we may not have the patient may be negative for the screening, but now she comes positive. Then certainly I would like to evaluate this patient again, and then definitely if her risk has increased, then in those situations, I would like to start her on low dose aspirin, certainly 24 by 22, 24 weeks. And the dosage, again, we go to various talks on pre-eclampsia as well as, so the people are saying 75 or 150, but I think FMF and NICE, everybody is now suggesting a dose of 150 milligrams to be taken every night. We'll continue with that, and then again I will bring back the patient to see what her blood pressure is and how she generally is doing, and not earlier than 24 weeks after this I would like to assess her for an ultrasound scan assessment, unless there were some really worrying features on the scan done at the 22 and 24 weeks of gestation.
Thank you. What about the clinical surveillance for this girl? Would you like to see her more frequently in pregnancy, or you'd be quite happy?
I'll bring her back. That's what I said. Yeah, that's what I said. I'll bring her back in a couple of weeks to check her blood pressure. And in fact, if she has a home blood pressure monitoring, I will probably just ask her to do it maybe once or twice a week. See, doing too many blood pressure readings also makes the patient very, very nervous. But certainly I will make her aware of any warning signs of preeclampsia, like persistent headaches or any visual disturbances, which obviously come in very late during the disease. However, if she feels that she's suddenly putting on too much weight, there is increasing edema or anything like that, then she should come back and report me. But as of now, I'll bring her back at 2 weeks and see how her blood pressure is. And if certainly the blood pressure starts going up, then my evaluation for her may be reduced to as frequent as every 2 days, every day. It depends on how the patient is doing.
Yes. Thank you for that input. Our next question is for Dr. Satjeet. We heard about MOMs, and some of the people who are new to our programs don't know what a multiple of median is. What are multiples of median, and why do we use them?
So multiple of median, this is a measure of how far an individual test result varies from the median value. For example, in context of preeclampsia, if we talk, like if the PLGF result, median PLGF at 13 weeks of gestation is 60 picograms per ml. And the patient test result is 30 picograms per ml. So the MOM values will be obtained by dividing the patient result by the median for that patient population, which in this case will be 30 divided by 60 or 0.5 moms. So this implicates that her PLGF values are half the normal. And specifically in context of preeclampsia, the MOM values, they vary with the gestational age, the platform which is used to measure the PLGF, and also the maternal demographic characteristics. And originally they were, the moms were used when to compare different lab results of maternal alpha-fetoprotein levels. And nowadays we have, like we know, we use them widely for Down syndrome screening, for screening of NTDs and preeclampsia. So like it is used to compare the results of a screening test if the values are highly variable. So we have moms to compare that.
Thank you. And our next question will come soon. And meanwhile, the patient has had a very uneventful pregnancy up to 30 weeks. And at 30 weeks, she presents with a dull headache for 1 day and a blood pressure of 142/92 taken at home. And this question is for Dr. Gitanjali, a management plan for this patient now.
This patient initially was low risk, but in the second trimester scan, she became high risk because uterine artery PI was increased. So now when she comes to me with a blood pressure on 142/92 and some dull headache, I will take her as a high risk patient. She's a high risk for early onset preeclampsia. So again, at 30 weeks, I have to be very careful. I will first monitor, take her blood pressure once again, and try to be in a calm circumstances so that the patient is rested, well rested for 10 to 15 minutes, take her blood pressure again. And then if the blood pressure still remains above 140/90, I will take her blood work, do her urine routine, dipstick test. Along with that, I'll send all the baseline investigations, whenever we are taking care of a patient of hypertensive disease or pregnancy, which includes a complete blood count, RFT with electrolytes, liver function test, then coagulation profile. It's a little too early, but since he falls in the high risk, yes, I would like to do that also, a coagulation profile, LDH levels, and an ultrasound for fetal growth, fetal Doppler, uterine artery PI again assisted, and amniotic fluid volume, and also for her. And one more thing, I will not send her home. I will keep her under observation till her tests come and do some BP monitoring, maybe for 24 hours for her.
Wonderful, thank you for that. Her urine shows a 3+ proteinuria. The liver and kidney function tests are normal range, and she has a serum uric acid of 9.1. The platelets are normal. Her coagulation profile was also done following this, and that was all right. The ultrasound revealed a fetal weight on the 22nd centile and normal amniotic fluid. So the question here is for Dr. Ajay Agarwal, would your ultrasound evaluation include Doppler, and which vessels would it include?
It is quite clear now this patient is preeclamptic. She's having albuminuria and she's having slightly raised blood pressure values. So we need to bring in the Doppler now, and we need to assess whether there's any uteroplacental dysfunction. Start looking at the umbilical arteries and the fetal MCA. Now, if these values are fine, then we need to...
Light तो बंद हुआ. Light तो नहीं गई. Light गई तो generator चला.
Yeah, go ahead, Ajay. Go ahead. Yes.
Yeah. So, like I said, we need to start doing the umbilical artery and the fetal MCA and see these vessels. The fetal percentile was 22%, so its baby's growing okay. The Liker looks fine. But we look at the Doppler, and if this is fine, then we keep the patient on, short interval follow-up. Perhaps 2 weeks, and then reassess again.
Yeah. And in your Doppler, would you just do an umbilical artery, or would you extend that?
No, I would go for the fetal MCA as well. And if these are fine, look at the cerebral placental ratio.
Yeah.
And if this is fine, then it's okay. Otherwise, if there is any changes, then go on and look ahead at the ductus venosus.
Wonderful. So we do multi-vessel Doppler, and we'll go ahead and assess this. And Dr. Maneet, what is your protocol in this situation?
As Dr. Ajay has already said, this is a patient who has established preeclampsia. So uterine arteries are not going to have much role in this patient. Umbilical artery Doppler, the MCA Doppler, as well as the ductus venosus are what I would do in this patient. Because that would decide my further surveillance as well as for the timing of delivery in early onset preeclampsia.
Now, all vessels show a normal range impedance, and her follow-up is uneventful. And the good news is she delivers spontaneously at 38 weeks plus. The fetal weight was 2.65 kilos, and the APGAR was 10 by 10. Baby happily went home. Incidentally, this was a spontaneous vaginal delivery, and she had spontaneously gone into labor. So this is one nice, happy story. And it's wonderful how, in spite of the fact that we have a few hiccups along the way, we can reassure ourselves, not just rush into delivery just because she has a high blood pressure, panic about that and say, okay, we can't help you. And of course, I presume that when SFLIT and PLGF become available far more widely, we'd be able to perhaps send them home and not keep them in hospital because we'd be able to rule out or rule in an eclamptic event. So thank you very much for giving this wonderful outcome. But before we end the case, I want to know about neonatal considerations here. And this question is for Dr. Pradeep Sharma. Any special neonatal considerations?
Yes, sir. Since this was a case of preeclampsia, one must look for morphological IUGR in the baby, just like an old man look, and its complications like hypoglycemia, polycythemia, hypocalcemia, and these mothers need adequate support to ensure breastfeeding. Otherwise, some of these babies later on end up in hypoglycemia, which may be undocumented and one of the important causes of neurodisability. So they need monitoring more than any other baby, although most of them do very well just with that. Thank you.
Wonderful, thank you. Any final comments from anybody on the panel? Yes, Dr.
Yeah, I would just like to add, like you were saying, yes, if we have SFLIT and PLGF ratio, it will make our life much easier because if they are available at an affordable range, once the patient comes with visual disturbances, some blood pressure monitoring, if you can do rule in and rule out, if the levels are less than 38, it will make our life much more comfortable. Yes. Especially if we have can do the rule out thing.
Yeah, we have
with the levels less than 38.
We have good news from one of our industrial partners, and they promise that it will become available in about a month or so, and also at a reasonable cost because we promised them bulk just because we have so many patients to look after. We needed some permissions from the drug controller, and Dr. Revati in Bangalore and our place in Delhi have managed to give them enough information that it works in our patients as well. So it's now going to be available outside a trial system, purely commercially available, and that would make our life much easier. And may I remind our audience to keep throwing things into the chat box so that we can answer those questions as we go along. And we move on to our next case. And this one is a 22-year-old primate, and she presents at 33 weeks with minimal antenatal visits. She's not really been there, maybe one odd one here and there. She was at her mother's place. She made one visit, and she comes in and she has visual disturbances, and she's swollen all over, and she has a little slip of paper that shows a recorded blood pressure of 165 by 100. So in this situation, my first question is for Dr. Gitanjali, a plan of management, please.
She's 22 years old, primary gravida from maternal history, a high-risk case, with no antenatal visits, coming at 33 weeks, again with high blood pressure, generalized edema, and visual disturbances. Everything fits into a case of early onset severe preeclampsia. And with visual disturbances and a high blood pressure of 165 by 90, she may be a case of imminent eclampsia also. So I will manage her like this. At the initial go, I'll make her take tablet of labetalol 100 milligram. Meanwhile, I'll gain IV access and do all investigations. Again, the blood work starting from complete blood count, including platelets, liver function test, renal function test, urine routine, and 24-hour urine collection, then coagulation profile, LDH, and take her blood pressure again. If the blood pressure is again 160, above 160 and diastolic above 100 or 110, I will start IV labetalol for her. And since I have an IV access now, I will take that much of time. In the meantime, I've already given an oral tablet to her. And IV labetalol is given at a dose of 20 milligrams slow IV. And also I will give her magnesium sulfate for prophylaxis of eclampsia. And the prophylactic dose is again 4 gram IV as a suspended regimen, we'll give it. Along with that, arrange for an ultrasound for fetal well-being, and also give her antenatal steroids, because we are at 33 weeks. We do not know, I do not know at the stage at which the patient comes, what will be the next management and how she will progress, because I do not know any antecedent history. So I will have to do everything in that moment only and be prepared for whatever comes next. Along with that, I will start the IV regimen for the management of eclampsia, that is syringe pump for magnesium sulfate at a dose of 1 gram per hour. I usually do that. I do not give the intramuscular injections at this time, which I find very barbaric. So I give it at a rate of 1 gram per hour. That is, you add 5 ampules of magnesium sulfate to 500 ml of normal saline bottle, and it becomes at a rate of 100 ml per hour. That is 1 gram per hour. That is the same dose. So that is, and of course, I actually be admitted under admission.
Thank you. Dr. Zini, any additional inputs apart from this? I think you have to unmute yourself.
Oh, sorry. No, I'm unmuted. Am I not?
Yes, yes, we can hear you now. Yes, yes.
Okay. Right. So I agree with Dr. Gitanjali.
We're not hearing you consistently. Naveen, are you able to hear her?
No, we are not able to hear you, Dr. Zini.
I think there's some connection problem. So if you can go ahead and
we could probably ask somebody.
I got disconnected. Sorry about that.
Wonderful, great. So now we can see you and hear you, Dr. Zini.
Thank you. So I could hear all of what Dr. Gitanjali said, that she is going to admit this patient. She's going to send off all the blood profile, urine tests and everything that should be done, because this is a case of severe pre-eclampsia. She's added magnesium sulfate to this patient. Of course, then I evaluate while I am stabilizing the mother. I also start evaluating for any fetal compromise. So start doing a cardiotocograph for this patient. She's already 33 weeks of gestation, clinically assess the growth of the baby, and then plan an ultrasound scan with the fetal Doppler and amniotic fluid assessment. Meanwhile, also get some steroids on board if I'm clinically feel, because if she's severe preeclampsia, I don't know which way it's going to go. So I might get antenatal steroids on board in case I need to deliver this patient early for maternal or fetal considerations. And those are the main things that I will be doing. And when I do and request my radiology colleague to do all the obstetric ultrasound scan, all the obstetric Dopplers, and based on the findings of her reports and the patient's, the baby's reports, I decide which way to go.
Wonderful. You know, we're so impressed that our obstetric colleagues have all these protocols worked out fit-pat without any controversy. It's marvelous, and we really have to try and do this in all our associated fields as well, including genetics and ultrasound. And when she's admitted and monitored, her blood pressure remains uncontrolled over the next 2 days, and she shows readings of 180 by 114 and a significant proteinuria. So the question then is, Dr. Zini, what next?
Deliver her.
Wonderful.
Give her. You've already should have started steroids 2 days ago, because she is severe preeclampsia. Let's get that definition right. BP is over 160 by 100. She's 3+ in proteinuria, so she's severe preeclampsia. So I do not have much time to hold on. So I would have got to be given steroids. I will plan her delivery.
Yeah, so the same as we already discussed.
And then inform Dr. Pradeep.
Very importantly, and we will have his input on this as well. So first, Dr. Gitanjali, and then of course, Dr. Satjeet, any additional inputs on this fetal medicine point of view?
First and foremost, intra-op and post-op, the patient may deteriorate anytime. I should have facilities for managing it. Those are very important for the patient concern, especially post-op, fluid management, urine output. She's a high-risk case, even post-op, 24 to 48 hours. And yes, it's a 33-week baby. We should have NICU facilities. Neonatologist should be there to take the delivery all the time otherwise, and NICU facilities to transfer the baby if required. Other than that, what we have SFLIT and PLGF ratios, if we have the luxury of these ratios, and these ratios if done at the initial time, suppose when she comes 2 days before, and if the ratios were high, what the consensus statement has said that if the ratio before 34 weeks, is higher than 600, 665, that is the figure that I've given, you have to deliver within 48 hours, start steroids immediately, give magnesium sulfate for neuroprotection, and deliver within 48 hours, because any adverse event in the form of APH, antepartum hemorrhage, or fetal death, stillbirth, anything can occur. So if we have an absolute value of, if we had the luxury of SFLIT, PLGF ratio, and we had some values that could have guided us much better about how this pregnancy will go, sudden deterioration could have been predicted to a much greater extent.
Yeah. And Dr. Sajid, your inputs on that?
Dr. Sajid, please unmute yourself.
Yes. So I think it has been very well summarized by Dr. Gitanjali and Dr. Zini. But I would like to comment on her initial visit 2 days back, when if she comes for an ultrasound, we may additionally find evidence of any fetal growth restriction and any Doppler abnormalities. And we can, that can also guide her timing of delivery if she's having absent or reverse and diastolic flow on ultrasound.
But tell me, clinicians, Dr. Gitanjali and Dr. Zini, if I were to tell you that a Doppler is completely bizarre, would you still go through with your follow-up steroid dose, or would you just...
We'll go by simply it's very clear. We follow the Barcelona protocol. If it's a reversed end diastolic flow, severe FGR, then I'm not waiting to deliver this patient. Then Dr. Pradeep will have to get ready with the surfactant. I'll give a loading dose of Maxilf, but usually that I reserve for patients less than 32 weeks of gestation. However, if I have a reduced end diastolic flow or absent end diastolic flow, but a reasonable CTG, I will put her on a continuous CTG monitoring, and then maybe I'll still wait for the steroids to take effect. So a reverse end diastolic flow does not, it warrants immediate delivery because already things have gone out of hand. At 33 weeks, I'm not looking for ductus venosus at this time. It's 33 weeks of gestation. I know I'm getting a good baby at this time. So I think the neonatology team can look after that baby.
Dr. Gitanjali, your inputs? Are you comfortable with following exactly this?
At 33 weeks, any changes in umbilical artery, I will be more worried, and I will, if it is reverse or end absent, I would like to, and MCA Doppler also I would see. If the MCA Doppler diastolic flow is increased or the CPR is increased, then I would like to reverse. So then I would like to take the baby.
Wonderful.
Out.
And so, Dr. Pradeep, do you always have the luxury of such brilliant obstetricians? I mean, you have to demand antenatal steroids and magnesium sulfate. And what is the protective effect of these on the neonates?
Yes, sir, definitely. I will request for antenatal steroids if we get the time for that, because it decreases the mortality, respiratory distress syndrome, and even intraventricular hemorrhage, including NEC. So the benefits are huge. And regarding magnesium sulfate, although the most of the guidelines say till 32 weeks of gestation, so if it is giving some protective benefit to the mother, I think we'll be happy to give that. But magnesium sulfate neuroprotection, the guidelines, although say till 32 weeks, but there is nothing that changes from 32 to 33 all of a sudden. It is mostly the number needed to treat increases. But if it is beneficial to the mother, I will be happy to get it done for the neuroprotection of the baby also.
Wonderful. Well, she had a cesarean, of course. There was no choice. 1.225 kilos, not bad at all, which makes Dr. Pradeep's job a lot easier compared to the 900 grammars and the 645 grammars that he has looked after for me. And the question then is postnatal considerations. How would you follow this baby up in the nursery?
Sir, one is this baby is at increased risk of neonatal depression at birth. One is it is premature, secondly IUGR with a complicated course. So resuscitation according to that prematurity should be available. Secondly, these babies are at risk of hypothermia in the delivery room and later on also. So I keep on asking the obstetrician to switch off the AC even if the warmer is on. And then what we do is we put these babies in a plastic wrap without removing the amniotic fluid from the baby's skin. So without drying the baby, just put the baby inside the plastic wrap. And then if the baby is depressed or is not breathing well, one can give TP's resuscitation even on the delivery table. Then these babies have respiratory distress for which they may require nasal CPAP and or surfactant. Most of these babies do not require mechanical ventilation at this gestation. Then are the complications in the NICU like hypoglycemia, polycythemia, hypocalcemia, sepsis. Sepsis is very important for these babies to be taken care of because the GI function is disrupted. The poor flow to the gut increases the translocation of bacteria from the gut to the blood vessels. So these babies are also at increased risk of neonatal sepsis, necrotizing enterocolitis. So we need to be very, very cautious in giving the feeding to these babies. We are often very slow and preferably expressed human milk should be given. Nowadays, if EBM is not available in the NICU, as some of the times most of the mothers will not be able to express so early, so artificial human milks are also available and these can be considered for such babies.
Wonderful. Thank you for that very concise but very...
Sir, can I...
Yes, of course.
Can I add one thing?
Yeah.
Because I work quite closely with Dr. Pradeep, we've always had a fight about this, that I'm not going to let you feed the baby early if there's any problem with the Dopplers. Because NEC is something that is so important in these cases because of the redistribution of the blood, that the gut already is ischemic. So I think it shouldn't be thought that if they're getting hypoglycemic, it has to be corrected with OG feeds. Secondly, what I have also found useful is if already there is a compromise in the Dopplers, if the resources are there, we can do an umbilical artery pH at the time of delivery by blood gases. So that gives a guiding way to the neonatologist, which is also helps them to prognosticate how this baby might do later on. So their resuscitation can be guided by that too.
Yes, that can be helpful.
Pradeep, are you happy getting cord blood pH or?
Sir, cord blood pH does help us because in this case, anyhow, we are not able to start feeds where the Dopplers are so abnormal. Mm-hmm. But if the cord blood pH otherwise in abnormal, even with normal babies and severely abnormal, so sometimes we are slow in feeding those babies also. So that is helpful if we get that.
Thank you. The comments should keep pouring in and we will have time for them. We now have a 5-minute quick, rapid discussion on the fact that not all seizures are eclamptic. And this is a 24-year-old primate and she comes in at 5 months. Don't ask weeks here. No antenatal care. She's had a seizure, obviously a grand mal, and loss of consciousness. And a brother reveals to us that she has a stormy marriage. She's been on anti-seizure medication since the age of 13, and they don't know what medication. And the husband's family is not aware of this. And her blood pressure is 164/96. So now we're going to wade through all of these, and I'm going to go step by step. Dr. Zini, how can we differentiate between eclampsia and epileptic seizures? I mean, can we?
Her blood pressure is high. See, her blood pressure is high. She's 5 months. She's nearly 20 weeks. For me, this is eclampsia unless proved otherwise. I always go by that protocol first of all. And my treatment protocol anyway will not change. She is having an epileptic seizure. I'm going to start her on magnesium sulfate because either which way it's going to protect her and it's going to provide a brain stabilizing function. So I will start with that medication. Then, of course, my first point is, of course, get my ABC done, catheterize the patient, stabilize her, get the IV access, send off all her bloods. And depending on that, so the regime starts with the magnesium sulfate, and then I start looking for other things for pre-eclampsia. So as we have already discussed, all the blood work, and then look for other things. Eclampsia, it's very difficult to distinguish between an eclamptic seizure and a seizure because of epilepsy after 20 weeks, especially with the raised blood pressure. My first differential always will be pre-eclampsia.
Dr. Gitanjali, any inputs here for us, please?
I agree with Dr. Zedi. Yes, she said everything. We always will take it as a eclamptic seizure. Only thing missing here is usually eclamptic. She has had just one seizure, but yes, we'll always treat it as a eclampsia only. The management will go that way.
Yeah. So
we have a blood pressure.
The most dangerous. We'll go right ahead. Yeah. Wonderful. So you see, she had the access of a hospital that had done this, and she had an S-split PLGF ratio on day 1 of 584.89, and on day 3 it went up to 1175, which are way above everything. Her blood pressure remained difficult to control. She had a fetal demise at 25 weeks. They didn't agree to a delivery before that because her in-laws would just said, you do what you feel like. And we had the neonatologist come in. On the second day of surgery, she had a severe PAPP-A. Why she required surgery, of course, was that she was just having seizures, nothing to control her. And there was no way we could sit and wait for ripening the cervix and so on. So inputs for her future reproductive career, please. Dr. Gitanjali?
Yeah, first and foremost, I will advise her to at least maintain an interpregnancy difference of more than 1 year at least, because any difference less than 1 year by risk factors has shown to be a more high risk factor. Second, proper monitoring for eclampsia seizures. You need to consult a medical specialist, a neurologist for that. And thirdly, if she is belonging to a lower socioeconomic status, many a times they are those who, somebody who's had not many visits, then I'll do minimal guidance for her. I will tell her that she needs to visit the nearest PHC as soon as she gets pregnant. I will also write down the name of Ecosprin for her, because she may or may not, if she belongs to a low socioeconomic status, she may or may not visit a health worker, health provider in time. So I'll write down Ecosprin and tell her to start this as soon as she gets pregnant, or maybe by 3rd month of pregnancy, and tell her to go to a basic PHC for BP checkups, and advise her, caution her about regular BP checkups. And once you put a fear of this in her mind that yes, her BP checkups are very important, the reason for this is, and you counsel the family well about it, they do understand it. That is as far as, and then yes, if she belongs to a higher socioeconomic status, there are other things that have to be ruled out. Acquired thrombophilias have to be ruled out. If she is a affording patient, all other tests have to be done before she plans her next pregnancy.
Yeah.
Like acquired thrombophilias have to be ruled out. PAPP-A and all those tests should be done for her. And also you do counseling for her future cardiovascular risk also, because of this kind of a career, and how even later on she needs timely guidance and supervision.
Yeah. And would you then start her at the beginning of pregnancy on 75 milligrams? I know this is a very naughty question. Or would you start her on 150?
No, sir, we are with you. We are with FMF. We'll start her on 150. Unless she weighs less than 40 kgs. Yes. Unless she weighs less than 40 kgs.
Yeah, yeah. No, she's well nourished, well fed. It's just that there is this terrible lack of relationship from both sides, boys' side, girls' side nonsense that you and me encountered every day. So Dr.
Yeah,
Z,
we do.
any other inputs?
I think again, me and Dr. Gitanjali are absolutely on the same page. Gap of 1 year. Do APLA profile, look for any thrombophilias because she might need additional Lonopin in addition to aspirin. Then risk scoring, I don't know what her age is, but risk scoring, and then I would be more careful, and then I will follow the full protocol of screening her again, right from the NT scan, going on from there, and maybe more frequent ultrasound scans. One very important thing, sir, in between that 1 year that she's waiting, let's see what's happening with her epilepsy. Because I'll ask her to get in touch with a neurologist also, because, you know, if she is not well controlled, then she should first control her seizures, be at least seizure free for 2 years if it is epileptic seizure, and then be stabilized on an anti-epileptic medication. And then if she's on an anti-epileptic medication, so start with high dose of folic acid before planning the next pregnancy. So that will always be in the back of mind that this could have been epilepsy also.
And in terms of the drugs that you would work with the neurologist for what in terms of teratogenicity, which is the least bad out of
Lamotrigine and carbamazepine both are fine when we look at the anti-epileptic drugs, and levetiracetam is also quite helpful. Other than phenytoin and valproic acid, I'm happy with most of them. Although levetiracetam and these are the drugs. The three I'm happy with.
We have a very Dashera festival in Dr. Pradeep Sharma's place, which is a reminder for us to, to wind up.
Wind up.
Yes. But before we go, there is this very exciting development that I wanted to tell you all about, and it's something called Congo Red. And it's going to become available in India pretty soon. And we're starting a trial at the All Indian Institute of Medical Sciences and some associated centers, which is coordinated by the Society of Fetal Medicine. And it's based on a urine test. And we know that in patients with serious preeclampsia, then you have Congo Red, which binds to the misfolded proteins in their urine. And when we put it onto this cellulose membrane paper, we get a different pattern, as you see at the bottom of the screen. So the more Congo Red is bound to the misfolded proteins, thus the dye spreads more evenly on the membrane, and therefore it gives a pretty good detection rate. And we do hope that in our kind of a background with this mixed patients, with these mixed socioeconomic categories, this will then give us some hope. So in addition to the availability of SFLIT, which the Society of Fetal Medicine has been pushing, we do hope that this comes in too. You see, our aim has always been not just to discuss academics, but also to push industry into supporting us. And we do feel that research taking any place else needs to be translated rapidly. And people used to say, how can you associate with companies and promote one or the other or the third? The fact remains that if we don't do this, we will actually never have this available. NIPT, for instance, has come down from 35,000 rupees to something between 8 and 15,000 rupees today for a good quality NIPT evaluation. Of course, the counseling is definite, but because we did this, we brought back those patients to us and not directly from company to market. And I think preeclampsia is going to be the next place where the availability of SFLT, PLGF, and Congo Red will help us. So we have good news for the future. And now I'm going to stop my screen share. And thank you, my panel, for this absolutely marvelous attention. But please do not go away, because I'm going to check the chat box finally and see what we have received in the chat box for answers. And the first question is, what is the prophylactic dose of Maxsulf to prevent the convulsion?
Same as the treatment dose for eclampsia. So 4 to 6 grams. The Dhaka regime is 4 grams loading dose, and then 2 milligrams, 1 to 2 milligrams per hour. So there is no difference. Even the prophylactic dose in severe preeclampsia remains the same.
Yeah. There was also a question on that on the uric acid being high in that patient, 9.9, in our second patient, 9.1. So we do realize that we may not have been able to wait 38 weeks. So Dr. Gitanjali, would you then monitor the uric acid and all the other parameters before you take a decision and perhaps deliver earlier?
In the newer definition, uric acid values as it is are not included, and they are not taken as a prognosticating factor.
Yes.
So it shows whenever the uric acid is high, there is an increased risk of having a SGA baby or having some maternal or fetal complications. There's another thing. If a mother is chronic hypertensive and has superimposed preeclampsia, so diagnose that, sometimes uric acid may be helpful. But other than that, uric acid does not help us.
Wonderful. That really sorts out the questions that have come in. And then, of course, there was this question of heparin in preeclampsia. And I think Dr. Liona Poon answered that for us. There is no replacement, and that there is no role for heparin unless we prove an associated immune disorder in this particular patient. And that, of course, we would investigate now. So that actually completes our list of questions. Any parting shots from my panel before we close our panel and rush off to our homes to see what kids have done? We don't have to rush off to our homes, unlike other meetings. We just have to step out of our rooms. Any other inputs, please, from anybody on the panel?
I can just add that if you sensitize all gynecologists to S-split PL-GL ratio, it will cause a huge demand for it, because we are really in need of it. We have to face the music when the patient suddenly starts fitting and doesn't show. A 120/80 BP patient and has just right epigastric pain early in the morning, and then you come on and suddenly the patient starts fitting. So those kind of things we can pick up quickly. So once the gynecologists, obstetricians are sensitized to it, the demand, there's a huge demand, because in India, after PPH, HTP and its related conditions are the major killer. So these webinars will really spread the knowledge.
Right.
And Ashok sir, Dr. Poon has mostly talked about the ACOG and the NICE and FMF guidance, but now in India we are all following the gestosis score, and I'm routinely using that as a screening tool at the first visit, and if any change in parameter is there, then I redo the gestosis score. So I think we must all at least start with the gestosis score. And many of our radiology colleagues in Ludhiana are doing fantastic work. They're doing all these things that we're talking about in terms of doing the uterine artery PIs and everything. So we are doing better, much better in the last few years than what we were. So I think these are the things that we should take home.
Yes, also that we're actually waiting for an official release of the gestosis score, which is due any time now. And I was speaking to the authors of the gestosis guidelines. I think a contingency screening, as you have suggested, is best, that we do a gestosis score, which is, there are many more parameters in that score, but that's easy. We can train our office staff to do those. And our office staff is much smarter than office staff anywhere in the world. I must confess.
You just have to, I just have a sticker on my desk, and then just quickly take it off. It's very
tick, and we go right ahead, and we get the answers that we're absolutely looking for. And therefore, I think once the gestosis score gets published, that would be nice. Yes, Naveen.
Yeah, I would like to add one thing. Like, we are talking about SFLT and PLGF ratio. I would definitely second that opinion. But before that, I would like to, on two aspects, the obstetricians, I would like to encourage them to use PLGF in the first trimester. And for that to happen, I would want the companies to, you need to have a little reduced rates for PLGF, so that in a low resource country like ours, so that we could help that into our FMF screening protocol for preeclampsia.
Yeah, Naveen, we've taken this up at the central level. And although a lot of people who don't like our little PENTA tests that has been released by one of the companies, the fact is that both the first trimester quadruple and the first trimester PENTA include the PLGF. And the total cost of these tests is now coming as a package if you bargain with these people. And what I was seriously starting to consider was that we have a practical note on how we should handle our evaluation in India for this. And I was wondering whether Dr. Gitanjali and Dr. Zini can take that lead for us, and then we put it into a national document that we pass. Not a bunch of 7 pages, 8 pages, no, one single page saying this, and Appendix 1, Appendix 2, Appendix 3. Would the panel be with me on this?
Yeah, definitely, sir.
Definitely.
Yeah. So
Yes,
I
sir.
think we have a very illustrious panel here, and I'm sure we could go ahead with this. And with that, I'd really like to thank everyone and hand the floor back to the Ludhiana chapter for taking this on to closure.
Thank you, sir.
Thank you, sir. It was
Yeah.
wonderful
Thank
being
you
with
so
you.
much, sir.
Yeah, thank you, Khurana sir.
Thank you,
This has been wonderful 2 hours, 50 minutes. Thank you for getting Dr. Liona Poon for us, making this meeting so special for a small regional chapter like Ludhiana. And then again, how can we say that once you conduct a panel discussion, it is like kind of extraordinary, and everybody is glued to all the information, and everything is so much, learning outcomes are so much better when it is there, and it's always very interesting. I just wanted to add to this PLGF thing. So now, since last couple of years, we are doing PLGF in all our first semester cases, and companies have responded very well. So I'm aware of at least 2 companies who offer us double marker with PLGF in rupees 1,500. The only problem is that they are still assuring us that they will be doing every day this test, but till this time, what happens is either they do 2 times a week or they once a week. So that gets our biochemistry result quite later, say after 1 week. So I would request that all our clinicians who are here, and they are very good number, I'm really thankful that at least 300 of them, they took out their time on the Shahara on this Sunday and spent these wonderful 3 hours with us. So I will request them all that preeclampsia is such a big problem in the pregnancy, and as we have seen that this is possible to reduce at least 80% of early onset severe preeclampsia at least. And overall, if we talk, even then the reduction or prevention can be very, very significant. So it is our duty. Let us make preeclampsia screening integral part of our comprehensive first semester scan. And let us do better. Let us help our pregnant mothers. Let us help our fetuses and have better outcomes. I thank everybody, all our panelists who have been illuminating us since last 1 hour. And I also thank Dr. Naveen Pereira, because he's the one who has taken care of this meeting day in and day out, giving calls to everybody, taking care of everything. Wonderful job done, Dr. Naveen. Thank you very much. And thank you all our delegates. If you do not join, what is the use of this meeting? Thank you, everybody.
Thank you, Deepak. And on that note, I will just add that without everyone's cooperation, especially Sir Khurana, who's been the guiding force and mentor for us, and we would wish him to continue doing so and guiding us in the future too. Thank you so much.
Thank you, Naveen, and thank you, everybody.
Bye-bye, everybody. Happy Dashara.
Right.
Bye.
Happy Dashara.
sir.